Welcome everyone. I'm Megan Carley, the project coordinator for the California Evidence-Based Clearinghouse for Child Welfare, or CEBC for short. I'd like to thank you all for joining us and welcome you to the webinar. We've muted your phones due to the high number of participants attending. So if you're experiencing any technical difficulties or have any urgent questions, please use the Q&A pod that's located to the right side of the screen, and we'll do our best to assist you. We will have a brief Q&A section halfway through and then at the end of the webinar. Please use that Q&A pod to send us any questions you have. Lastly, you will receive a link shortly after the conclusion of this webinar to complete a short and easy survey that will continue to improve our webinars and make sure they're as useful and beneficial as possible. Now, just a brief introduction of our presenters. Dr. Richard Barth is the Dean of the School of Social Work at the University of Maryland. He has also served as a chaired professor at UC Berkeley and University of North Carolina. He has authored many books, chapters, and articles on children's service practices, programs, policy, and research. Most recently, his writing has focused on parent training and its interaction with child welfare and understanding the common elements of practice. He has won many awards of his excellence in research and social work. He is a fellow and president of the American Academy of Social Work and Social Welfare. Also, he has served as a lecturer and consultant to numerous countries, states, and universities. Kyla Leggett-Griel is a clinical instructor at the School of Social Work, University of Maryland. She served as a senior clinical social worker at the Center for Infant Studies for 3 years. She was previously a supervising clinical social worker at Kennedy Greger Institute for 9 years and coordinated a clinic for children between the ages of birth to 5 who had experienced trauma. She has presented for child welfare agencies across the state of Maryland on issues related to trauma, attachment, and development. Currently, she is working on the development and evaluation of manualized parenting programs in the state of Maryland. And now I will pass it on to Kyla.
Good morning to the West Coast and good afternoon to the East Coast. We are excited that you all are here for this webinar. We were scheduled a couple of weeks ago, but Sandy, the hurricane, came to visit, so we're glad that we were able to reschedule and you guys were able to join us.
Thanks, Kyla. Good to know that we're reaching so many people today. I wanted to mention that we are presenting from downtown Baltimore, where the University of Maryland is, right in between the fire station and the shock trauma center. So if you hear a lot of sirens and ambulances, it probably isn't about the presenters. It's something that will just pass in time, but it's a great venue for us to talk to you from.
All right, well, we will go ahead and get started. We will be talking about parenting programs for children birth to 8, specifically what the evidence is and what seems to be the common components. Our learning objectives today, we are going to identify and describe current evidence-based education models that are being used in child welfare. We are also going to identify common elements that are used in parent training for children under 8 years old. And we're going to discuss how some of those common elements are different when you have families with children 0 to 3 and then 4 to 8. We are going to describe the evidence behind some of these models. And we're really going to talk about the differences between manualized education programs and a common elements-based approach. And we're also going to talk about next steps in this area because we're in an exciting period of growth and development. So, with that being said, parent training and child welfare. The reason this is such an important topic is that about 800 families are involved in some sort of parent training, whether it be for prevention or intervention. It is used to help with reunification for families, and many more families may experience prior training in child welfare involvement. There's more and more progress in offering evidence-based programs to child welfare families, but it's slow, but it does seem to be gaining ground. This is an exciting time of research, especially for children birth to 3 years old. So why are we focusing on parent training? We know that it is directly related to child overall welfare and influences outcomes like behavior, educational success, and emotional well-being. We know that when parents do have positive parenting skills, that it helps young children meet developmental milestones and have positive and social emotional relationships, not only with their parents, but with peers and other adults. We know that knowledge of parenting skills and basic understanding of child development has been identified as a key protective factor. The more that parents understand about what child development looks like and what a child's needs are, we see improved parenting skills, and that interprets into improved development in young children. There are several theories that underlie parent training. The first being that parenting skills can improve with training, that we know that when parents are offered information, that parenting skills can change, that they're not stuck, and if there are negative or challenging parenting patterns, that with information and support from educators and interventionists, that these patterns can be broken and new skills can begin. We know that child outcomes, especially in early childhood, can change. We can improve child outcomes. When we see challenging behaviors for preschoolers, or we see a lot of irritability and issues with self-regulation for younger children, that with parenting intervention, that some of those issues can be resolved and better functioning can be reached by the time they go to elementary school. We also know that parent training can reduce the risk of child abuse and neglect. When parents have the skills to recognize the needs of their children and they have the ability to meet those needs in a healthy and positive way, it will decrease the chances that there will be physical and social and emotional abuse and neglect. We also know that characteristics of effective parenting include the interaction style with their child. Some parents may be rejecting, or they may be negative or even scary at times. And so part of parent training really focuses on improving that interaction style between the parent and child and helping parents recognize when a child is communicating a need versus it being a negative projection or meaning given to the child. We work a lot on warmth and affection towards the child. Sometimes this is more difficult than other times when you have parents who have had negative parenting experiences in their own childhood and maybe learned some negative parenting skills, that affection can really be triggering to parents, and that triggering can cause some major behavioral changes or self-regulation changes or changes in accessing patterns in young children. And finally, parent training really works on parenting strategies used. So really helping parents that if they have one skill base and they're intervening with their child in maybe the not most supportive way, that we offer some strategies, concrete strategies that parents can use to respond to their young child's needs. Now, early childhood, this is a great time to intervene. We know that if we intervene during the birth to 5 age range, that major changes can take place. This is when children are developing the fastest and the most. This is when their brain is developing, they're learning a lot. Their brain and their being are learning how the world is going to function in their life, whether it's a safe place or a scary place. And we know that it has shown to decrease the rate of child maltreatment. Kids in early, between birth and 3 are especially high risk for child abuse and neglect. And we'll talk a little bit more about that. And so it is the most effective time for the prevention and intervention of child conduct problems, really because at early childhood it's developmentally appropriate and typical that children are going to have temper tantrums or hit, and that's just what happens with 2- and 3-year-olds. The issue is how the parent responds to this to help them manage some of these developmental milestones. And so we intervene in a healthy and supportive way so that these don't become behaviors that are a pattern. A 2-year-old hitting, pretty typical development. When an 8-year-old hits, it's a much bigger issue. So parent training in particular by the California Evidence-Based Clearinghouse for Child Welfare talks about services to help parents improve of and communication with their children with the goal of reducing the child abuse and neglect and or reducing disruptive behaviors. And so with parent training, it's not specifically related to early childhood, birth to 5. So you'll see on the next slide that we talk about infant-toddler mental health. And this is defined as a way of conceptualizing early attachment disruptions. And we're going to talk about attachment theory in a minute. And intervening through parental caregiver guidance, supportive counseling, and parent-infant dyadic psychotherapy. And we'll talk about how important it is that you're working with the dyad, that both parties are important in the change process. With infant and toddler mental health programs, there are several programs that are identified as either well supported by research evidence or supported or promising research evidence. This is exciting that there are some choices available for practitioners who are working with children 0 to 5, but you can also see that the choices are limited, especially for the age range of birth to 3. There are no well supported by research evidence interventions for birth to 2-year-olds. There are some supported by research evidence, and more research is being done, and so hopefully they will be well supported soon. And you'll see that with child-parent psychotherapy. And then we have some promising research evidence in some of the models that, like ABC and Circle of Security and TheraPlay. So right now we're limited in the choices that we have, but we're early in our research process, and now more and more research is being done, and we think that there will be more evidence-based practices that are well supported, and we'll get a good idea of what common elements are the most effective with the young population. Parent training models, these are for all ages, and you can see by this list that there are many more choices for practitioners who are working with their older children. Just with the well-supported, with the early childhood, we have 1, none for birth to 2, but here for the older kids, there are 4 listed. And you'll also see that PCIT, the parent-child interaction therapy, is in both categories of parent training and infant mental health. So Dean Barth will talk a little bit more about the older parenting training models later on in the presentation. But this is really to give people a good idea of how the area of early childhood intervention parenting training for children birth to 3 is limited at this point, but growing, and it's a time of great excitement development. So here's another list of these different models for parent training and infant mental health. As you can see, there is some overlap, which is really interesting and exciting. And we're going to talk about theoretical foundations and how the theory that's supporting these models are helping them function in both parent training and infant mental health. It's certainly true that when you're working in infant mental health, parent training is always involved, whether it be talking to parents about child development or talking about how children change day to day, and helping parents really have concrete skills on how to respond to the needs of their children and to recognize when their child is communicating to them through crying or smiling or crawling to them. And we'll talk more about that in a few minutes. So why is this different? You know, I'm just saying that with infant mental health, there is a parent training component. So what's the difference between parent training and infant mental health? Well, you can see by this slide there are there's two theoretical foundations that underlie both parent training and infant-child mental health. And one is social learning theory, and the other one is attachment-based. And so right now there's a big split between the two arenas, but there are some models that I think are meeting in the middle, and you can see that PCIT was both in parent training and infant mental health. And more, we think that models will come out using the strengths of both types of theory. So attachment theory. This attachment theory is really looking at the idea of the internal working model. It's based on Bowlby's work and Ainsworth. And the internal working model is really based on when a person is between birth and 3 especially, that their primary caregiver is their attachment figure. And that primary caregiver is letting that baby know what is the world like. Is it a scary place, a responsive place, a safe place? And this is communicated by how the parent responds to the child's needs. So if a baby cries, if the parent responds and feeds the baby, then that lets the baby know if they have a need, somebody will respond, and it's a safe response. On the other hand, if a baby cries and they're met with yelling, rejecting, ignoring, neglecting, or in worst case scenario, physical abuse, then what they learn is the world is not a safe place, and their cues are going to be affected by that, whether it be that they become more irritable because if they're rejected or neglected, they may find other ways of trying to cue, like increasing their crying. For the older kids, it may be hitting or even sometimes biting. And if they're met with hitting or any type of other physical abuse, then they really may become withdrawn, and you may have a baby who's not cueing anymore. And so that becomes the internal working model, the idea of how they're going to experience the world and what they think about themselves. So when you're looking at attachment theory in infant mental health and parent training, the goal is really to address that internal working model through considering where that came from and making a better understanding and have a better lens of the world and what their interaction with their child may look like. Social learning theory, on the other hand, really is based on the idea that parenting skills are learned through their experience with their own parents. And the good news based on social learning theory is that because parent skills are learned, they can be relearned. They can be learned through role modeling and mentoring and scaffolding, so that if a parent is having some parenting skills that are really negative for the child or not supporting their growth and development, that through learning from a professional, an interventionist, a teacher, a therapist, whoever it may be, that they can learn those new skills, practice them, get feedback on those skills, and then be able to implement them from that point forward with their children. So you can see here is the breakdown of the theoretical foundations. And as you can see, parent-child interaction therapy lays in both attachment and social learning theory. So with the attachment category, you're going to see in those models more work on the parent's understanding of what the child means when they do things like cry, or if a baby reaches up and grabs a mother's hair or puts their hand on their face, a parent may interpret that as something that's abusive or hostile if that's what their experience with parenting has been in the past. And so those models are really going to try to address some of that interpretation and whether or not the parent is being triggered. And that's going to be done through interaction between the parent and the child, live feedback from the interventionist with the parent, and also some conversations with the parent about what their childhood was like and what they want their child to experience with them. With the social learning theory models, there's going to be a lot of discussion on skills, specifically how do you teach your child something? What concrete skills do you use when parenting? Like if your child has a fever, what do you do in that situation? If your child is having a behavioral issue, how do you respond with a specific strategy, such as, for an older child, it may be timeout. And so you can see that there's a difference between those two types of models. One is really considering the inner working model of the parent and how they're interpreting the behavior, versus social learning theory models, which is focusing more on concrete strategies on supporting their child's development. So when we're talking about evidence behind some of these models, what we know for parent training infant mental health is that it does increase social competence. For the older children, it's their social competence, whether it be with peers or adults. And for the younger children, we're really looking at the social competence of the parent. You can have a 2-year-old where you are working on social competence, but it's really in the way of giving them social emotional skills, such as language to say, I'm sad. And that's done with the parent modeling it and supporting them with active teaching of social emotional skills through, looking at books or talking about feelings of characters that the child may be aware of. It also increases positive parenting skills, so that the parents can know that positive reinforcement, consistency, responsive parenting, that these are the best ways to help children meet developmental milestones. We know that it increases the parents' coping skills, so that if they are feeling stressed or overwhelmed, that they have ways, whether it be through reaching out to other adults or doing relaxation, or sometimes it's just stepping away and recognizing when you're really being triggered by your child. We also know that this helps with positive parent-child interaction. It increases the interaction that's joyful and exciting and fun for both parties. Really easy for parents to sometimes fall into the trap of just giving orders and demands and not having the pleasurable interaction that they need to have with their child, so the child understands that the world can be a supportive place and a good place to be, and that adults can be supportive and a positive resource to access. We also know that it increases problem-solving skills. We all know that as a parent, every day, sometimes every minute, new problems arise, new things, new developmental milestones are hit, and with those come new challenges. Whether it be that your child who's crawling is now walking and you have to clean things out of their way so that they can't reach dangerous items on the table, or what to do when your little one is having difficulty playing with other children because they started biting because their language is just coming in, but they don't know how to use it effectively yet. We also know that it is effective in decreasing negative child behavior. If we have a parent who is responsive and using skills to help a child use new developmental skills and emerging developmental skills in an appropriate manner, it's going to decrease a child's negative behavior, such as a 3-year-old who may be biting. And because we know that parent training does decrease child abuse and neglect, it's going to decrease out-of-home placement. If children have lower negative child behavior, or if parents have a better understanding of why a baby might be crying or irritable, then that's going to decrease the chances that there's going to be abuse or neglect happening because the parent is being triggered without understanding what's going on. And by giving parents new skills and experiencing what parenting can be like in a pleasurable way, then it's going to decrease harsh and ineffective parenting skills. If a parent only has experienced harsh and ineffective parenting in their own childhood, these are the only tools that they may have. And so through parent training and infant mental health work, we're giving them new skills, new tools, and helping them understand their child's cueing in a more positive and healthy manner. So the exciting thing is we are entering the next frontier with parent training and infant mental health for children birth to 3. Unfortunately, there have been a large group of children entering foster care for the past 20 years, and we have more kids who are in foster care who as teenagers are having children. So we now have 2 generations in the child welfare system, and those teens, we know they've had attachment disruptions if you're basing it on attachment theory, and we know that they've learned negative parenting skills based on social learning theory from their primary birth family, which is why they're now in the child welfare system. So the work with parent training and with the infant mental health is helping those teens recognize what's happened in their past, what parenting skills they have, and what parenting skills they need. And sometimes that's through concrete conversations with them about what do they want for their child's future and how can they help them achieve that goal. This really is done where the teen parent and the child are interacting in real time right there with an interventionist or a trainer. And it's really important to pull in that foster parent because that foster parent is there at bedtime when there's a high risk that the parent is tired, the child is fussy, and there may be some negative projections like this baby just doesn't want me to sleep, this baby is always bothering me. If a foster parent is there, they can help address that even at 10 o'clock at night, whereas interventionists and the social workers, we're not there. So we're not going to be the best tool to support that teen parent. The other thing is there's not much evidence about optimal birth to 3 models yet. We're early, we're getting more, and we're researching more around elements and procedures so we have a better sense of what's going to be the most effective. Does anybody have any questions so far? You all have a chat box that you can type questions in, and we can take a couple of minutes right now to answer if anybody has any.
And I see a few that have come up on the screen. So one of them is the $800,000 a year static yearly? And I think what I could say about that is that comes from data from the National Survey of Child and Adolescent Well-Being. And that survey was done in the late part of the 1990s and early part of 2000, and it was collected then. So some of that may have changed, but I think the key point is that with the vast number of children who are substantiated for maltreatment and go into the formal child welfare system, that number has been pretty stable. Although not as many kids are going to foster care, the number of substantiated cases is reasonably stable, and most of them still get some kind of parent training. Although for the most part, it is very unlikely to be a recognized evidence-based kind of parent training, the kind of programs that Kyla was talking about earlier. With alternative response growing, I expect that there will be more people who will get parent training in community settings, perhaps than through the formal child welfare system, but I wouldn't expect that number of 800,000 to drop too much.
The next question is regarding CEPL, and they ask, have you looked at CEPL pyramid model for positive social emotional behavior parent training model out of Vanderbilt University? The answer is yes. This is a model that has been implemented around the state of Maryland. Head Starts, early Head Starts, the public school systems, a lot of them have been trained, and University of Maryland has been a leader in the training. They have a new model in the past couple of months called PWE, which specifically focuses on supporting parent-child interaction through building attunement, where parents are asked to guess how a child may respond to a new toy. They introduce the new toy, and then the parent talks about what they noticed in the child's interaction with that toy. And then there's also the training offer is for teachers, daycare providers, and we're excited to announce that here at Maryland, we're going to actually start training entire community on CEPL type of interventions, everything from firefighters to teachers to child welfare workers, to really focus on that social emotional competence, and we're going to weave trauma into that so that we can build up those skills while also recognizing the effect that trauma has on young children.
Another question is about promoting first relationships. Is that not considered an evidence-based practice? Now, in our initial polling that we did, we realized that some of you are not that familiar with the California Evidence-Based Clearinghouse. And let me just say a bit about that, because that helped to determine which programs we listed under what category in this presentation. The California Evidence-Based Clearinghouse requires that people submit their materials related to their interventions, and then these are evaluated using the definitions that are quite transparent on the website. And when there are additional questions about it, these come to the Research Advisory Board for review, and then final decisions are made by the California Evidence-Based Clearinghouse. Promoting first relationships has not had published rigorous studies till now, although I know that there is a study that's in press at Child Maltreatment, because I wrote a commentary about it. I was asked to write a commentary about it, that does provide some evidence related to the use of promoting first relationships in a child welfare involved population. So this is good news. It's not a absolutely definitive study, and it's just one study. And to get, for example, to the highest level of the clearinghouse's ratings, you have to have at least 2 studies that show an impact. But I think it's certainly a program that has a long history and has the promise of perhaps moving into a higher level of evaluation in the California Evidence-Based Clearinghouse. We're looking at some of the other questions. One of them is, for the 0 to 3s, is there any evidence the new triple P baby model is effective? And I do not know. It's not been separately distinguished in the California Evidence-Based Clearinghouse, as far as I know, but you can all check that out for yourselves. So I think at this point, my understanding is that there's no separate evidence about the triple P baby model. There's a question about which of these approaches work best with parents who are victims of domestic violence. What is the evidence, and how do you get parents to participate? So there is a category on the Evidence-Based Clearinghouse about domestic violence, and I'll be mentioning one of the studies later on in my presentation, so I won't repeat it here. But yes, there is some promise now of effective parenting intervention for, in this case, women who have left the shelter and have returned home. And it's an in-home program that was designed to try to help improve their parenting and reduce, in this case, they measured the improved behavior of the kids, of their kids in their care, and showed effects. And almost inevitably, not necessarily inevitably, but very likely, if you see conduct of kids improving, it means the parenting behavior of parents are improving. It also very often means that they are more satisfied with their parents. And there's a growing collection of evidence that also indicates that parents' mental health is better when they do better parenting and when their kids' conduct problems are decreasing.
There's a question about what impact do adverse childhood experiences have in parent learning, and did your study include asking the parents about their childhood experiences or trauma? We certainly feel that a parent's childhood experiences creates a lens for the parents around the interactions with their child, whether their child is interacting with them in a negative, harsh way, even when it may be a typical developmental behavior or action. I think that with parent learning, when you have a parent who has a trauma history, it can be more complex because you're having to change their beliefs rather than just teaching new skills. If a parent comes in and believes, well, the best way to put a kid to sleep is this way, but it's not trauma related, it's pretty, you can say, well, actually, this is a great way to put them to bed, and setting up a routine and ritual. And so it's a little bit easier. If a parent really believes the world is this scary, harsh place, and you're trying to teach this new skill, there may be a little bit more defensiveness And you could pretty easily trigger some of the parents' attachment and trauma issues that may come up.
So 2 last questions. One of them is, what is known about love and logic model, and do your charts show only those programs that are evidence-based? I'll answer the second part of that. Your charts show only those programs that are evidence-based. In my perspective at least, the California Evidence-Based Clearinghouse has the best process in the world for evaluating what programs are effective with child welfare populations or populations that are have some overlapping characteristics with the kids and parents who typically become involved with child welfare. So we use that, yes, and we used it broadly in this presentation. So we didn't just, as Kyla described before, we didn't just include those well supported by research evidence, which has the most rigorous definition, but we also included those that are supported by research evidence and also that have promising research evidence. So the programs we mentioned here are all identified as at least, because they have at least promising research evidence by virtue of the, I think, quite precise evaluations of the California Evidence-Based Clearinghouse. One last comment about that is that I got a message from the California Evidence-Based Clearinghouse that promoting first relationships is about to be loaded into the CEBC as a number 3, promising research evidence. So in the future, you will see promoting first relationships on the California Evidence-Based Clearinghouse.
Just a real quick answer to a question, is CEFL considered evidence-based? It is not considered evidence-based, but it is informed by, it's all strategies and interventions and frameworks that are based on evidence-based. And so to answer your question, no, by itself is not considered evidence-based. Okay, we're going to move on to the next portion of our training. Thank you for those wonderful questions, and there will be a period at the end to answer more questions. So we're going to talk about the parent training components. Specifically, we're going to look at what are the goals of some of these parent training, why do we do these things, what are the essential program components, what do we feel are the most important, or the things that we see many of the models doing, and then the clinical components, so that we can look at specific intervention tools that are being used. We're going to break it into the two age ranges, 0 to 3 and 4 to 8. But the intervention goals generally can be broken down where there are specific parenting skills. So teaching parents to give positive attention to their children, how to praise their children. PCIT in particular has a specific breakdown of how to give praise to your child, and how to model behaviors, whether it be using specific social emotional language with young children, naming and labeling their feelings. They also talk about effective methods for reducing difficult behavior. Again, that's for older children, so the dean will speak to that, because again, with birth to 3, we're really not talking about behaviors, but rather things that young children do to communicate needs, their developmental and emotional needs to their parents. Also, looking at helping parents with activity preparation, that they need to plan ahead, they need to have practice at being ready and prepared to interact with their child, because if they're disorganized in their interaction, then the child becomes more disorganized. A lot of the models have child-directed play. This is a specific intervention that really helps the parent be able to be responsive and attuned to what the child is trying to communicate. And it teaches the child that they're important and they're special and that the parents want to know more about them. And so you would have a parent-child in there, and the child would have blocks, and they might start building a tower, and the parent would build a tower with the child. This shows that this can be a really pleasurable interaction for both parties. We talk about parent-child relationships, scheduling time together, which can, we know, be a challenge for some of our parents. But talking about how you can weave it into your daily routine during times of cooking or cleaning or taking the bus. wherever they are, they can weave this in. Talking to the parents about personal skills, working on time management, things like bedtime routines, so that helping parents understand that if they really keep a routine and the child goes to bed early, they'll have some time for themselves and focus on their own needs. And then the child component for the older kids around social skills training. For 0 to 3, the program components, it is extremely complex to do work with families with children birth to 3, because you're not only working with the parent as a person, but you're also working with them as a parent, you're working with the child, you're working with the dyadic relationship, and as Selma Freiberg and Alicia Lieberman referred to, that there's ghosts and angels in the nursery that are in that room when you're doing the clinical work. The positive messages that parents have heard throughout when they were young children, but then also some of those negative interactions that happened when they were young. And so you're having to manage all of that in the room. With that level of complexity, provider qualifications is extremely important. At the least, a bachelor's degree, but you can see that many more require a higher level. The duration is very flexible. Some models do it in 4 weeks, and some say 42. And then there are programs that do home-based, especially with children 0 to 3, the idea of natural environment, where it's in the home using the tools that they have available to them. If you're doing play work, but you only have, you have the 1-inch blocks and the special dolls in your office, that can be great to practice, but in the home, if they don't have those tools, then it's hard for them to generalize in the home and practice those skills. Some of them do center-based, and there's a positive to that because it creates an environment where parents and children can focus on each other and there's no distractions. And it can be group-based so that they get social support.
I'm going to take us back just 1 second on this slide to take you through all these initials and tell you what the program names are, because you will probably relate to those more. I'm sure you've heard of many of these programs. It's partly because I'm going to be using the same initials and Kyla's going to be using them in subsequent slides. So only requiring a bachelor's, for example, are programs Parent Management Training Oregon. This is Oregon Social Learning Center's Parent Management Training Program, which was going on for 30 years. NPP is the Nurturing Parenting Program, which is probably one of the most widely used in child welfare settings. It's been used for many years without really much evidence. There's an older child version, and now there's a infant version or a young child version. I think the evidence is starting to accrue, and that's why it's in the California Evidence-Based Clearinghouse. Safe Care is a program that involves, fairly brief, it is an in-home program developed in Illinois. Now has a very nice trial that's recently come out showing its impact over a 5-year period in terms of reducing neglect and abuse of children. And Triple P, the Australian program. 1, 2, 3 Magic is a very basic program, which is also in book format and highly used. No program is really highly used across child welfare, but amongst those that are used, 1, 2, 3 Magic is pretty common. And COS is Circle of Security, which is an attachment-based program that uses video materials for teaching and other techniques which make it reasonably efficient, and it's just now starting to gather some evidence. CPP is Child Parent Psychotherapy, which is a year-long program that Alicia Lieberman developed and which has some good evidence for it. Parent-Child Interaction Therapy, we've talked about before. PCIT, I would argue, has the best evidence of any of the programs in terms of reducing child abuse reports and improving conduct problems. TheraPlay is a intervention that's listed as being effective or as being appropriate for children 0 to 18. I frankly don't know that much about it. It was developed, I think, primarily for kids 0 to 3, but has apparently some efficacy with an extended age range. And then TIY stands for the Incredible Years. I think that covers all of them. Back to you, Kyle.
Thank you. We also know that for families with children birth to 3, it's really important to have both parties involved. Doing work with just one, either the parent or the child, I believe, does not have the same effectiveness as working with both, because you have to have that dyadic interaction to really have the effect. Some models do happen in group format. A benefit to this is that they can expand their social support network. And then a challenge to that can be, it can be difficult to have parent-child interaction. It is possible, it is done, but it can be difficult because you might have a lot of distractions with other parents and children in the room. Most of the models do have some form of homework. Sometimes the homework are things like go home and play for 5 minutes with your child. And then there's also video feedback, which this is an important piece because sometimes parents really don't understand what their child's reaction really looks like or means. We talk about how children focus a lot on facial expressions. So when you have a parent-child interact and you videotape it and then show the parent, then the parent sometimes sees things that they just don't know is happening during the actual interaction, such as the child looking scared or the child disengaging by turning their head, or that maybe the parent's face is really making some scary facial expressions which are triggering to the child. So in summary, for infant mental health and parent training specifically for children birth to 3, it's really important to have both involved in the program. If you are just talking about skills but not allowing them to practice them, it's just not going to get as much uptake without the practice. Some programs do have group format. We have a group format here at the University of Maryland for our Parent University program. And again, it does expand the social support, which is especially nice when parents with young children who may be pretty socially isolated. Homework, tracking child behavior, and proximity seeking. Sometimes it is telling parents, did the baby crawl towards you, and when did that happen, and what did that feel like for you, and what was your response? Video feedback, which we've talked about. Some programs are using stock video, so it's not specifically of that parent and child, but rather other parents and children interacting. There are minimal professional requirements really needing at the very least a bachelor's degree, and those professionals should have training in child development and a lot of training to the specific model being used. The dosage generally is weekly for an hour, and it does range from 4 weeks to 52 weeks, but pretty much most of them are 4 to 20 weeks. Both home-based and center-based are used. Social learning and attachment are the foundational theories. I think for anybody who is doing parent training or infant-child mental health, it's important to learn about both of these theories because there are tools that come from both that are really helpful in doing this work. Doing both parent-directed and child-directed, that way they can be fluid in their interactions and the parent can learn skills on both sides. And then psychoeducation about child development and mental health is really important for parents to learn what's going on with their child so they can be more responsive.
So I'm going to take the lead for the remaining slides, talking about the 4 to 8 age group. Before I do that, I wanted to say that for the most part, we don't really have a very clear sense of whether which of these things are the absolutely most important. Kyla's comment before, though, certainly deserves underscoring, which is that unless you're getting people to practice in a way that has a high likelihood of their using the skills in their own settings, you're not going to have much impact. And ironically, Mary Dozier, who developed the ABC program, is in our building today talking about that program. Unfortunately, we overlapped with our scheduling, and we talked with her before this presentation, and she agreed. She said, the one thing that I hope you'll get people to say is it's not so much about what the theory is, it's not even so much about what the methods are, but they have to have a way of reaching people to both motivate them to try new skills, but probably as close to the home environment as possible. So it doesn't absolutely have to be done in the home, but if it isn't, there should at least be some expectation of practicing in the home and maybe calling to follow up with people to see when they're at home and to see how it went and things like that. So back to the prepared slides. I'm going to now try to do a similar kind of analysis that comes again from the California Evidence-Based Clearinghouse with regard to provider qualifications for the 4 to 8. For parents with kids 4 to 8, you won't be surprised to see that the provider qualifications don't really change that much depending on the ages of children who are involved. Those are basically fixed more by the developer than they are really relevant to the ages of children. The durations are about the same, although there's nothing as long as 52 weeks, which is the child parent psychotherapy program that was mentioned before for 0 to 3s. I do have a sense that I'll talk about later that 4 weeks is too short. From the general evidence-based practice work in a whole range of fields, from parent training to HIV prevention, 15 hours of training I would consider to be probably about the minimum. Many of them are home-based, but you'll see that many that are home-based have also been used as center-based programs as well. I think, as I say, if logistics can be managed, it's important to do these at home so you can observe the barriers that are in place, and you can try to engage the other members of the household in also supporting and participating in the activities related to parent change. With regard to clinical components, again, there is parent-mediated interventions where you're not working with the child directly, but you're working with the parent is critical to almost all of them. They do include a child component, but for the most part, that child component is coupled with the parent. So it really is parent-child component. Not always exactly at the same time. So in the Incredible Years, for example, you have a separate parent group and child group, and the children are getting more of a child psychotherapy, but they're also learning, they're playing with dolls and stuffies, and they're learning to put them in timeout and to praise them and to do the kinds of things that their parents are learning in a parallel process. And then they do sometimes come together for parts of the intervention. So not all of them, all of these programs have both going on, or are integrated with parent and child together, but for my money, that's the most effective kind of intervention if it's at all manageable. I think the days of having parents in one classroom and kids being babysat and watching videos, hopefully we can get the kind of resources we need to do more than that and can really engage either parents and children together or groups for the children simultaneous with groups for the parents rather than just child care for kids 4 to 8. The group format is also pretty common, and not all of these have, all of these do have an evidence-based when presented in groups, and Triple P has both a group model and an in-home model, for example, and they both seem to contribute to the success of parents in changing their behavior. There are some programs like PCIT that now has a group format that's under development. So we can all see the advantages of multiple family groups, but sometimes it takes a while to get the logistics worked out and to get the evidence to support those. Homework is vitally important to many of the most effective parenting programs for kids 4 to 8, and then video or live feedback. And the difference there is that in some of the programs, you're getting live feedback like parent-child interaction therapy by being observed and having a bug in the ear, or even some other way of even Skyping, depending on where the therapist is, while you interact with your child, so you're getting live feedback. In other cases, you may be getting, they may be videotaping you, or you may even be videotaping your own interactions with the child, and then the therapist goes through and calls out the interactions that where you showed the most effectiveness or where they want to give you feedback, and they use video feedback. I think those are powerful tools, although there frankly haven't been research designs that have really focused on, that I know of. Please send me a message if you know of some that have really focused on the contribution that that actual feedback makes above and beyond the other things that are going on in the parenting program. So that's where we are in the field. We kind of know in combination how these things work. We don't always know what the unique contribution of each of these strategies is. So for my thinking, from our thinking, I would say that the 10 common components that I would see as something I would want to see if I was in an agency and working with child welfare families and had a generic parent training program, and I wasn't able, for one reason or another, to get training to do the incredible years or training and space to do PCIT. These are the things I would want to see. Strong engagement and alliance development with the parent. So sometimes we think that social learning is all about instruction, but it's very much about relationship, for example. Demonstration of the skills to be learned, either on videotape or modeling by the therapist or sometimes modeling by other group members. A relentless focus on increasing positive behavior of the parent and child with praise and other rewards. As many of you know, not only the children in these households that have often never been praised or acknowledged for doing things well, it's their parents as well. So I certainly agree with the original premise of the original parent management training in Oregon, OSLC, that says that parents and kids should get 4 doses of praise for every dose of negative feedback that they get. And I think that's a critical part of the effective program. Requiring completion of behavioral specific homework each week with the child. There has to be habits have to be created and sustained, and we all know how challenging that is, and that's what these homeworks are about. Psychoeducation about child development and mental health. Many of our families don't know nearly enough about what's normal and what they can expect. Psychoeducation alone, like many of these other things, is not enough, and we've often been faulted for just doing psychoeducation, or I think we can be faulted for that, but it is important. Monitoring of progress by parents' progress, and the child's progress. So parents should become observers of how they're doing, and parents should become observers of how their children are doing. So they can see when children are doing better, and they can learn to praise them. They can also see when they're not making any progress and they need to do something different. And they can also learn to praise themselves. Methods to maintain engagement in the group. We don't have good data on how many families drop out of parent training, but I think it would not be unsafe to say that it's at least half of parents who start parent training programs never finish them. And so engagement is critical. And that doesn't just mean getting them there the first time, but checking in with them, calling them, providing incentives to come back. Just because they're under a court order is not enough incentive to finish parent training program. Requiring frequent behavioral practice in session, preferably with live feedback. We've talked about that before, but finding ways to get parents to practice behaviors is critically important. I would say at least 15 hours, I mentioned that before, of individual or 25 hours of group, but I don't have any overwhelming evidence to support that. That again comes from a more general analysis of behavioral group interventions in the human services. And then supervision of the group leader based on observation or listening. One of the other things we know is that an active learning strategy that not only provides training to the group leaders, but provides feedback to the group leaders and helps them to stay on task and helps them to maintain their positivity and their creativity are important to these interventions. And implementation science is telling us more and more about the importance of fidelity and good feedback. And you don't have to have a training manual or the developer of the training manual giving you feedback. There are other ways to do it that also I think can be valuable. Okay, so now we're moving into a little thinner ice. And so the California Evidence-Based Clearinghouse has asked me to post this warning to all of you that my formulation about the common components in parent training is not based on evidence or with approval from the California Evidence-Based Clearinghouse for Child Welfare. And I say that with a bit of amusement, but it's very serious. What they're basically saying is, although I have a connection to the California Evidence-Based Clearinghouse because I'm on the Research Advisory Board, I am not saying anything that reflects their perspective. In fact, I've never presented this concept to the advisory board or seen whether my colleagues agree with me. It's really more my digest of the work after a few decades of working in this field, and you are free to shut down the seminar at this point or to listen along. So the main question I ask is, can we be effective delivering parent training if we don't use manualized evidence-based packages? And the reason I ask this is because I know from not only this national survey that we did that showed that almost no child welfare agencies a decade ago were using evidence-based practices, and I know that's changed, and I'm pleased that that's changed, but that even though it is changed, I would be surprised if there were more than 20% of parents who were involved with child welfare that had evidence-based practices as their primary means of learning to improve their parenting. I suspect that there's still a great predominance of agencies that don't have access to packages like the Incredible Years, which I think very highly of, or parent-child interaction therapy, which I think very highly of. And they're trying to find their own way, and hopefully some of you are on the call, and this is helpful to you for this reason. They're trying to find their own way to give the best evidence-based intervention they can without having it be a manualized evidence-based practice. So that's what I'm going to be riffing about for the next few minutes. So before I do that, I've got these terms that I need you to know about, and I'm going to follow up and use some of these terms to explain my position. So one of the terms is common elements, and this is a term that Bruce Jorpita from UCLA and his colleagues developed. It's a term for what elements are most commonly found in the winning treatment arms of studies. So what does that mean? What they did is they've coded more than 400 studies now, not all of them about parent training, but a good number about parent training. And they've looked to see if you are in the winning treatment compared to another treatment or two other treatments, what is the likelihood that a certain element, like let's say praise, is used in your intervention compared to the other intervention. So these are common elements. The term is meant to refer to common elements in successful interventions. Another term is active ingredients. People often ask, well, what's the active ingredient? And I hope you know by now from what I've said that I don't really know what the active ingredient is. Nobody knows what the active ingredient is in most of these programs. They are a composite of various different elements. And for the most part, across the board, I really don't want you to interpret what I'm saying is that any of these things is the active element. But I do believe that the talk that we are giving today will help all of you to figure out what are some of the elements that are likely to be active ingredients. Essential components is the language that the California Evidence-Based Clearinghouse asks when it's the developers of these interventions to describe when they post their interventions on the California Evidence-Based Clearinghouse. So when you look at the description of any of these programs, you will see that there is a line that says the essential components. Now, not a criticism of the California Evidence-Based Clearinghouse, you have to pick some language, but we don't know that these are essential except in the minds of the treatment developers, which is a pretty good place to start. I won't criticize that, but it doesn't mean that we really know that they are active ingredients. So, and they didn't call them active ingredients, they call them essential components. We're using a term common components. So common components is our term for what we see as frequent elements in promising and effective parenting programs with no suggestion that we know whether these are winning or active or essential components, okay? So this is our definition, and that's part of what we've shown you already, which are the common dimensions of these different programs. And there's another term that's important, modular design or approach. And I won't talk about this a lot, but there's a study that I'll reference by John Weiss and Bruce Chorpita that uses this approach. And this is a multi-disorder model that integrates procedures of 3 separate treatments. In this case, treatments for kids with depression, anxiety, and conduct problems. I'll explain later why I need to talk about this. But basically, it's, in my view, a cousin of common elements insofar as they took 3 different manualized treatments and they looked for the things in those treatments, and they taught workers, half of them social workers roughly and half of them others, to use these elements in a relatively, in a way that had more flexibility than the manuals would have had. So there was some ability of the workers to vary which elements they used when and for how long, whereas those workers who used the manuals did them with high fidelity. So the comparison is between a more flexible or modular approach that takes these elements from the manuals and uses them in a way that the therapist thinks is, with some guidance, is better corresponds to the needs of a child as compared to, and parent, as compared to the manual approach. So that's the background. Sorry to put you through that, but it's hard to get this without having some idea about the differences we're talking about. So this is actually a slide from Bruce Chorpita, and some of you may think along these same lines, where after you've seen this long list of these manualized interventions, and they're for different age groups, and in our case, we're treating them all as if the parents have and kids have the same issues, risk of child maltreatment. In many cases, there are different manuals for different kids of different ages with different mental health problems, and this poor soul is saying, how will I ever master all these manualized evidence-supported treatments? If only I could figure out the basic elements, I could mix them, match them as needed. So this is, I think, one of the quests that the field is undertaking, and I think the common elements work that Bruce Chorpita has forwarded and that we've done a little bit of writing about here at the School of Social Work is important and something I want to talk about some more. So the question then comes up as, and I'm stepping back just a little bit here, the question comes up basically is good, effective parent training basically a commodity, a generic product that you can make by taking what we think to be either the common elements or the essential components or even just the common components? And could you be as effective doing that as you need to be? Could you be as effective doing that as you would be if you used one of the brand products like Triple P or PCIT, where you have to go through a developer and you have to get trained and you have to sometimes pay a license fee and so on? And so as I was thinking about this, I was thinking about the more general concept in medicine and just the general marketplace about commodities versus specialty or brand name goods or services. And I won't read through all of this, but the basic question that I am trying to answer, only for parent training for kids 4 to 8, because I do think that we now have lots of 35 years of evidence about this effort, is that you could have a generic kind of parent training program with no special distinguishing characteristics that is basically a commodity that people could use without having to pay for a special brand name training and all the training that's and all the costs and things that are associated with that. And that's the controversy, okay? That's where I think that I may differ from at least some of my colleagues, or at least we can say there's no real evidence that this is true, that I think that parent training for kids 4 to 8 can be a commodity. I don't, even though I like some of the brand name programs, I think if you could do some of the things that they're doing and that we've been talking about today, you would basically find that you could create an intervention that was basically as efficient as these specialty or brand name goods or services are. So I'll try to make that case a little further, and then we'll wrap up this part. So before I mentioned that there's this intervention for mothers who had left domestic violence shelters that was developed and provided in-home services. And here's an example in my mind of why I think you could do generic parent training programs. This intervention was developed, basically the treatment manual was a textbook written by Rick Dangle and Rick Polster in 1988. And they also used the Forehand and McMahon's first edition, written in 1981. So they didn't get fancy parent training. They basically went to books you can get on Amazon, and they did two things very important. One is they delivered the intervention at home, and secondly, they provided really good supervision to the interventionist. So they did the things I was talking about before, where they gave them regular feedback in terms of how well they were doing with implementing what they had read in these textbooks. Okay, and what they showed, and this is why this intervention is now recognized by the Clearinghouse, is they showed greater improvement during parent training and continued improvement even 6 months later with regard to kids' behavior problems. So you can see that at the very beginning of the intervention period, the CBCL, Child Behavior Checklist, was in the very high range, 65 to 70. It came down for both the treatment group and the intervention group, but it continued to go down for the intervention group over the next follow-up period. And this, to me, is, at least in my interpretation, a good sign that if you use these basic principles, which we've been writing about now since 1981 or earlier, was it 91? In any case, a long time, that you can get good effects in a difficult population. So this takes me to thinking more about the common elements approach. And this is the approach that I mentioned before, basically where you look for elements that are in effective interventions, you borrow those strategies, you teach those strategies to clinicians, and you help them to use them in a flexible way to match them to particular client characteristics. There's a long process that you have to go through to develop these, but it's not particularly complicated. You have to have a commitment to being sure that you're picking elements that are associated with success, that you sort of have to have an emphasis on evidence-based treatments. You have to compile them into, in your own way. When you do this, you would draw on what other people have done when they compiled them into manuals and tested them, and then you would basically pull them out of those manuals and begin using them yourself. And there is one study that is not an evaluation of common elements per se, but it's very promising, which is this John Weiss, Bruce Jorpita study I mentioned before, the modular approach to mental health, that shows that when you use the treatment manuals, the evidence-based treatment manuals, or you compare that to this modularized approach where you take the elements out of the manuals and you let people use them somewhat flexibly, that you get a better outcome. Not only did they get a better outcome than the manualized approach or the standard condition, but they did it in a shorter amount of time. So youth in the modular treatment showed significantly faster improvement than youth in usual care on overall and parent-reported behavior problem measures. They outperformed the standard treatment on behavior problem measures, and they showed that also that the outcomes in the standard manual condition were not as effective in their implementation as they thought. They did not surpass the usual care. So the only condition that really was effective was the modularized approach. So again, a reminder, this is not common elements per se. This is not a true test of whether you all out there in the community can take these elements from different training manuals or from textbooks that are commonly thought to be associated with effective parent training and put them into play. But I'm willing to take a risk based on reading this literature for more than 30 years that you could do very much like those who read Dangle and Polster and McMahon's work in implementing a powerful parent training program without having it be pre-manualized or tested. But this research is all that we have now. We still have more work to do in testing this common elements approach in parent training and child welfare. So my conclusions: parent training for children 4 to 8 is now entering middle age. It's dependable. It's time to go generic. If you have no evidence-based practice available, build one from the common elements or common components or essential components of the evidence-based practices that are available. That parent training for children 0 to 3 is not at that stage. I don't have the confidence that you could develop your own intervention for kids 0 to 3. Unfortunately, child welfare has not really paid a lot of attention to this, so there's quite a bit of catching up to do. And I think it would be a good place to go, and we should go there, but it's not ready yet. Of course, I need to again mention that purists may not agree with my perspective. More science is needed in comparing approaches to parent training programs. So I turn it back. I want to turn it back to you to raise your hands and ask questions, but that's not going to work, is it? So instead, I will read some of the questions that our staff has so generously summarized for us. And we're scrolling down now to see what else you have added. Are there any recommendations on either focusing on attachment or parent training in home visiting with paraprofessionals? It's a great question. My sense is that there is a somewhat better history of teaching people who don't have extensive mental health training to work as more on the social learning side than on the attachment side. But I'd be interested in hearing from Kylie if she knows of more attachment-based interventions that have been delivered by paraprofessionals.
I think that generally it's been in combination where you may have a primary interventionist where they do the lead in the work, but then they may have a paraprofessional who visits with the family. They may help with some case management, concrete needs, do some observation, maybe videotape, and then take it back to the primary interventionist to get feedback and to sort of offer guidance on what the next session may focus on.
Another question is, can you restate the difference between parent training and infant mental health? Very briefly, I would say that for the most part, there doesn't need to be a big difference, but they have tended to cleave so that infant mental health has tended to be much more psychodynamic and attachment-based, and parent training has tended to be more social learning based, and yet both of them do best when they're done, I think, in settings that are going to be most likely to generalize, when the parent and child are together and they can learn together. And so I would say, and what we were trying to say is, yes, there are some historic differences, but that we see many more commonalities about what would be effective in the delivery of those programs than is often talked about.
One question is, are you saying that if parents don't have their children with them and only have supervised visits a couple times a week, that parent training will not be effective with those parents first to 3? No, I think that one really nice model is if child welfare workers are trained in supporting parent-child interaction and child development, that those interventions can be offered during parent-child visits. And it's very effective, and I think it can generalize. And it makes some of the visits easier and more productive because the parents feel like they have something to do and that it's a learning process. So I do think that this can be offered during visits.
Another question was, do we have recommendations regarding tools or assessments to use to evaluate the extent to which parents are learning specific skills throughout a series of training sessions, and recommendations for the size of a parenting group? Great question. For that reason, the California Evidence-Based Clearinghouse has added a whole section on assessments, which we didn't have at the beginning because this question comes up as it should. Parent-child interaction therapy, in my view, is far and away the best of all the parent training programs because they really test parents on competencies like observing and praising their children, and until they pass those competencies, they're not finished with PCIT. So when you go to court later, it's not just they showed up for some parent training or they passed the parent training program, but these are the things that they actually demonstrated that they were competent about. And of course, parents get a big kick out of it too. Are there particular models that work best for parents' substance use disorders? This has been a big question for a very long time. There's no easy answer to it. The one thing that I would say, though, is that if you think about parent substance use disorders as being, in some cases, related to their general sense that they don't have any other way of interacting effectively with the world, and that the pressures of parenting and their partners and everything else are contributing to that substance abuse disorder, there is at least some reason to think that improving parenting, which can be done with people who have a substance disorder, again, depending on the level of it, not someone nodding out in the corner, but it can be done, that it can help to unlock some more positive behaviors in their general life, and that could include substance abuse, improvements in substance abuse. As I say, there's clear evidence it improves depression. And again, if depression is being medicated by substance use, it could improve it there. Lots of coulds there, but I do not think that we should say that having a substance abuse disorder would be counterindicated for learning to be a more effective parent. In all cases, those things can both improve together.
There's a question about culturally specific programs for the African American families. There is a program called Chicago Parenting Program by Deborah Gross, and that was participatory research that was done specifically with African American parents as an advisory board that really created the program and has found some positive results with African American families.
So I got a nice note from someone in San Francisco saying that they use several evidence-based practices, Incredible Years, Triple P, Magic 123, PCIT. They also have a couple of parent ed providers using homegrown programs, but they have to complete the same assessment tools as Triple P, and they have been getting some similar results. Also got a nice note from Judy Cohen mentioning that the Celebrating Families program is designed for use with substance use parents. Thanks, Judy.
Oh, the question about Head Start, it said please mention again the name of the model being used by Head Start. I'm assuming you're talking about CEFL. That's what was mentioned before, and that's CSEFEL through Vanderbilt. And if you type it into Google, it'll come up. Again, it's C as in cat, S as in Sam, E, F as in Frank, E-L.
And someone asked how evidence-based it is, and my recollection is that it is not so evidence-based. It's not known to be evidence-based with this population. But again, the great thing about the California Evidence-Based Clearinghouse, I can't tout them enough, is that you can check out whether we're saying squares with the current ratings of these programs. They change on a regular basis. They are very conscientious about updating them. And Love and Logic got a couple of questions, maybe from the same person, maybe from a couple of you. And I have to say that it is a pretty common and popular program, but I don't know as much about it as I might. So that's another one where I encourage you to look at the website, which I would be doing right this moment, as I do often during the week if I wasn't otherwise delivering this webinar. I think unless there are more questions, that we are in good shape to sign off and give you a couple of minutes to make it. Oh wait, there is one more. Are there parenting programs that have been reviewed for working with immigrant parents? Gosh, I hope so, but I don't know. There are people like Anna Lau, Lau, whose work you might look up, who has been working for many years on issues related to the cultural appropriateness of various interventions, especially parent training interventions. So I would refer you over to try to find out what Anna's been up to, but I don't know whether there are or not. But the good news is it's becoming such a big field that none of us can keep up with it alone, but it's been great having the opportunity to try to contribute a bit. We would welcome follow-up